Ladies and gentlemen, hope you're enjoying your meals. It is now time for our next speaker, and I'm sure that you will give him your explicit 100% attention. I'm delighted to invite James Simon to deliver his lecture on removing barriers and reducing risks when prescribing menopause hormone therapy. Thanks, Jim.
Thank you very much, everybody. Ladies and gentlemen, it's a real honor to speak in front of my colleagues. And as such, I prepared a complicated lecture. As you can see from this slide, I'm going to talk about removing barriers and reducing risks when prescribing menopausal hormone therapy. Because as you can see, there's a devil inside. Think about it. These are my disclosures. I present them honestly and straightforwardly, and I'm proud to have an opportunity to work with many of the people doing research and development in our field. So the learning objectives for this lecture are to apply relevant data so as to educate both our patients and our fellow practitioners about hormone therapy by eliminating or alleviating impediments to using that therapy, specifically by reducing thrombotic and thromboembolic events, one of the biological risks, and by mitigating breast cancer fears through a better appreciation of and appropriate context for the true risks of menopausal hormone therapy and breast cancer. I'd like to introduce you to the concept of a zombie idea. A zombie idea is an idea that should have been killed by the evidence but refuses to die. And it just keeps coming back and back and back. It was originally coined by Paul Krugman, who is a Nobel Prize in economics, but I think it applies quite well to our discussion this evening. So the zombie ideas I wish to discuss this evening are menopausal estrogen or hormone therapy causes deep vein thrombosis and thromboembolism, and breast cancer. Two separate zombie ideas. One, a biologic endpoint, thrombosis and thromboembolism. The other, a psychological impediment or barrier, breast cancer. Let's start not at the very beginning, but 2002, 20 years ago, with the initial publication of the Women's Health Initiative, something everyone in this room hopefully is familiar with, but maybe not the way I will present it to you. These are the results. The important columns, and I don't have a pointer, but the important columns here are the two that list the nominal and 95% confidence intervals. That's the column next to the big black column. And the column next to that, which is called adjusted 95% confidence intervals. And those are important to consider in any interpretation of any paper of any size. But the results were not as planned. When you do a clinical research study, you have to plan for how you're going to analyze the results. And the Women's Health Initiative investigators had a plan, and they published the plan. And I'll show you pieces of the planned publication or the plan analysis, which was completed long before the first patient was enrolled. And those investigators decided to ignore what they had written down as the plan because their study, according to the plan, didn't show anything. No risk, very little benefit, and they spent $1 billion to do the study. If I give you $1 billion, you better show me something. So look at the column labeled 95% confidence interval nominal, and you'll see some yellow figures, and you will see some white figures. And the important white figures here are breast cancer, because if you look, they even fudged the breast cancer by analyzing it a separate way, which took the lower bound of the 95% confidence interval for 1.00, not significant at all, to 1.01, and they claimed it was significant in the nominal confidence interval column. But that's not the column they should be looking at, because it wasn't a primary endpoint of the study as they defined it. I didn't have to define it, they defined it. That's the important number right there. Despite the fact that they fudged the data, and they should have been looking at the next column, 0.97 to 1.57, which is clearly not significant, which is the proper data point to report, the news media, as they were told by the investigators, reported the following: a 41% increase in strokes, a 29% increase in heart attacks, a 100% increase in venous thromboembolism, one of the zombie ideas we'll discuss tonight, a 22% increase in total cardiovascular disease, and a 26% increase in breast cancer. Well, on the news, after that, no one heard anything. Okay? Well, that big 26% increase is less than one whole person per 1,000. A rare event, documented rare event. And as Dr. Hirschberg showed you, that was accompanied by a media blitz. Let's put the media blitz in context. How many scientific papers are you aware of that have a paper in the Annals of Internal Medicine, not about the results of the paper, but about the media coverage of the results of the paper? I make that not up. The reference is right there. But that's not the first time. So let me take you back before some of you were born, 1989, when then Ms. Magazine had a cover story. And the cover story, it's difficult to read here in red, it says, "Dangerous Liaisons, Women and Estrogen, the Story They Want You to Swallow." 1989, April. And I looked at this cover and I said, I'm a gynecologist. I've been practicing for a bunch of years. I've walked in on innumerable patients in various states of undress, and I never saw a woman cover her breasts like that. Like this? Absolutely. Like this? Not so much. So I said to myself, what are they trying to say with this cover? What is the subliminal message with this cover? And that's the message: that hormones are in fact poison. You think about it. Mark Twain, in 1906, famous writer, US writer, said, "There are three kinds of lies: lies, damn lies, and statistics." So let's take a very brief moment and talk about the lies of the WHI and how to lie with statistics. And this comes from their paper published by Kerb et al. In 2003, but from a written paper from the 1990s, before the first person came into the trial, on the analysis plan. And you'll see two circles. One that says PHT, that's the postmenopausal hormone therapy part of the Women's Health Initiative. And right below it, with a big blue arrow, it says coronary heart disease. That is the only primary outcome from the Women's Health Initiative. It's the only outcome for which women coming into the study were randomized. They were randomized based on their baseline cardiovascular risk, period. And we're not going to talk about it. But we're going to talk about everything else because if you look at the analysis plan, breast cancer is a secondary endpoint. And venous thromboembolism, both pulmonary embolism and deep vein thrombosis, also secondary endpoints. What that means in simple terms is that those endpoints need to be balanced by a statistical manipulation to make the patients the same when they started out. So if 90% of the women went into this bucket, had blonde hair, and 90% of the women in this bucket had brunette hair, and we're doing a study on cardiovascular disease, but then we decide to analyze the effect of hair color on breast cancer, they're not even. So we have to balance it out statistically to make it even so we can make an adjustment and find out. The most common serious biological adverse events in the Women's Health Initiative were the effects of oral estrogen, ERT, or oral progestogen added to estrogen, PERT, and deep vein thrombosis and thromboembolism. And I'm not going to look at the 79-year-old women. There's no one in this room who would start a 79-year-old asymptomatic woman on hormone therapy. It wasn't done then. It's not done now. I don't know where those people are. But the answer is there are plenty of you who would start women 50 to 59 years old with symptoms and many without on hormone therapy. Maybe they don't have symptoms, but they have low bone mass. Maybe they don't have symptoms, but they have joint stiffness or joint pain. All of the symptoms that Dr. Hirschberg explained to you are part of the menopausal symptom complex. Well, in the Women's Health Initiative, the bad stuff in this trial, whether it's on estrogen or estrogen progestin, in 50 to 60-year-olds, 50 to 59-year-olds, that's a typographical error, 50 to 59, they were thrombotic risks. Pulmonary embolism far outweighing anything else. And if you want to look at the individual data points, in the top row are conjugated equine estrogens in surgically menopausal women. In the bottom row, conjugated equine estrogen and medroxyprogesterone acetate. And you see single-digit changes for risk in deep vein thrombosis and pulmonary embolism, 5 and 3 per 10,000 women per year. And if you're studying the population of Portugal, that's a lot. If you're talking to an individual patient, 5 in 10,000, not so much. And for breast cancer, it was a risk in the estrogen progestin arm at the bottom, 6 extra cases per 10,000 per year, but some good news, in the estrogen only, a decrease of 5 cases per year. But as you can see, the biggest bars overall are all down, they're all beneficial. So for 50 to 59-year-olds, most of the bars are going down, and some of them are going down a lot, like fractures. 16 or 25 per 10,000 women per year. Well, how does the route of estrogen administration, not part of the Women's Health Initiative, impact coagulation, deep vein thrombosis, and pulmonary embolism? Because if it's the biggest effect in the Women's Health Initiative, we should look at trying to mitigate that, right? I'm mitigating risks and removing barriers. That's my topic for today. Well, there's lots of data, and this is summarized in a recent publication by Graham, Archer, myself, and a bunch of other individuals, showing that the risk of thrombosis is highest in conjugated equine estrogens that have a lot of estrogens unique to horses, not a bad thing necessarily, but unique to horses that have a very long active time in the liver, creating very dramatic changes in thrombotic factors. And much greater effect than oral estradiol, which is typically the compound, whether oral or transdermal, used in the rest of the world, and much more than transdermal estradiol. And this is because that first pass through the liver has a lot of impact. Our liver is our chemical plant. All the food, wine, everything else you throw down there, including drugs, metabolized in the liver pretty much. And some of those agents not only get metabolized in the liver, but they cause changes in liver effects themselves. Some of them are listed for you here. I'm going to talk about clotting factors and anti-clotting factors. Without going into all the details and taking you back to medical school, nursing school, pharmacy school, etc., to explain the coagulation cascade, we're just going to talk about what changes what. And if you look, these are a summary of some older studies. I just happen to have a slide. It's not important. But the new studies look exactly the same. And it says T for transdermal, O for oral, each row in pairs. And you can see that for the transdermal route of administration of estradiol, you got a lot of NS, not significant change in these various thrombotic factors. These are procoagulant factors, fibrinogen factor 7, factor 1 and 2, etc. Or it looks the same if you want to look at anticoagulation factors, all made in the liver, by the way. And they look a lot of NS's for the transdermal compared to the oral in this slide as well. Not complicated, right? So transdermal, not specifying a product, not specifying a dose, transdermal in comparable doses in each one of these studies have less effect on the liver, in the liver, on clotting factors. Not complicated. Well, does that make a damn bit of a difference? I'm going to get criticized on Saturday by talking about intermediate markers. Okay? Well, this is an intermediate marker. It's not events. It's not events. But if we look at events, here's the Esther study. It's getting a little old in the tooth, but 2003, the Esther study, and the Esther study shows that there are more events, deep vein thrombosis and thromboembolism on oral estrogen, about a fourfold risk of an event compared to transdermals, even compared to non-users. So non-users and transdermal users have about the same risk of an event. I'll say that again. Non-users and transdermal users of estrogen have about the same risk of a thrombotic event, at least in this study, you could argue. What about people that already had a thrombosis or have a procoagulation factor? Anybody here from Leiden? Well, we have some Belgians up front. Factor 5 Leiden, that's from Leiden. Okay, factor 5 Leiden increases your risk of thrombosis. So if we put a bunch of women with known procoagulant factors like factor 5 Leiden or G20210A mutations, I know you know all about those, on transdermal estrogen or no estrogen or oral estrogen, you see a persistent difference between the orals. Let's take this big bar over here, 25.5-fold increased risk compared to no increased risk if you've got one prothrombotic factor on transdermal versus a non-user. Any country represented by an individual here have overweight or obesity as a problem? We do. They do in the UK, I can tell you that. Some of the Europeans, maybe not so much. But we do in the US. 2/3 of American men and women are either overweight or obese. I'm going to say that again just so you can imagine how fat we are. 2/3 of American men and women are either overweight or obese. So if you're practicing medicine in Washington, D.C., as I am, 5 blocks from the White House, the answer is you're going to see a lot of big women. And when I say big, I did some research on weight loss drugs, and I can tell you a woman with a BMI of 50 is a big woman. Biggest problem on doing a research project on women with a BMI between 40 and 50, no venous access. Their veins are this far from their skin. But the point here is that women, even women with an elevated BMI, who are on a non-oral form of estrogen, did not have an increase in their risk of thrombosis. It was only seen in women who are on oral estrogens. And this has been shown in a variety of databases looking at transdermal estrogen, which confers a reduced risk of venous thromboembolism. And these are your large databases. Those in the UK recognize the GPRD database. I showed you the Esther study, etc. Not new. This is reconfirmed in 2019 in this other study from the CPRD database, etc., demonstrating that in these large studies, there was no increase in the risk of deep vein thrombosis and pulmonary embolism in individuals who were on transdermal compared to oral estrogens. I heard of COVID. Anybody else heard of COVID? Well, it's wreaking havoc on all of our healthcare systems. Just be glad we're not paying the bills, that the government is picking up the bills. But the answer is, it's wreaking havoc on our healthcare system. And I commonly get questions about, well, aren't transdermal therapies more expensive than oral therapies? And in the US, the answer is yes. Absolutely true, they are more expensive. But in this study, we evaluated 13 million people out of the 350 million in the US, 13 million menopausal women. I'm glad I didn't do that data analysis. But in this study, we showed that even though the initial cost of the therapy was more, nearly 10 times more actually, that the cost of giving the therapy was actually less because we didn't have in that cohort deep vein thrombosis and pulmonary embolism and hospitalizations, which are really expensive in the US. About $1,200 to $1,500 US dollars. That's about 1,200 to 1,500 euros per day. You can avoid a lot of cost if you keep people out of the hospital. And we showed in this study an incremental savings of something like $55 per patient per month by giving them transdermal and avoiding the thrombotic risks. Well, what about progesterone and progestogens? How do those, usually given orally, and Dr. Hirschberg is going to tell us when her study is over what the story is there, because there are no good, large, randomized clinical trials, but how do those add to the estrogens, either oral or transdermal, and increase or not the risk of thrombosis or thromboembolism? Well, if you can read the small print, and it's difficult, the first horizontal line, and I'll read it for you, says current use of transdermal estrogens, just estrogens, and there's no increase in thromboembolism in this from the E3N cohort study. And if you look at the second line in this, it says current use of micronized progesterone, and again, no increase in thromboembolism in this cohort study. That's good news. Here's another one from the British Medical Journal, 2018. And while you may not be able to read the little circles, the first one says transdermal estradiol. The second one says transdermal estradiol and progesterone. And then it says oral in the final column, showing that orals increase the risk of thromboembolism, whereas transdermals and transdermals with progesterone do not. So, in regards to the route of administration, if you can avoid the first pass effect in the liver, you avoid a lot of metabolic changes you don't want, including the thrombotic effects, even in individuals with known thrombophilias. And this is reflected in the 2016 IMS guidelines that Dr. Panay was talking about revising. And I'm sure these findings, and I won't read them to you, you should know them if you don't already, but they say that transdermals are less likely to increase the risk of venous thromboembolism compared to orals. And on the subject of progestins, same story I just mentioned. The elephant in the room, which has a very loud name, you can never say breast cancer to a woman. It's breast cancer. It's breast cancer. It yells loudly. And when looking at risk perceptions and benefits amongst chronic diseases, the two arrows demonstrate that in women, what they perceive as the greatest risk in their lives, not in breast cancer and hormone therapy, in their lives is breast cancer. And what do they worry about? It's the big yellow bar. It's breast cancer. So you can't say it softly or with logic or with meaning. So let's get some historical perspective. Why do we associate estrogen and breast cancer? It's from data like this, and if you look at the second row of bars, you can see that the lifetime exposure to endogenous hormone concentrations, and the first set is estradiol, the second set is free estradiol. You can see a clear association. The more exposure to one's own estrogen, the higher the risk of breast cancer. But like many observational findings, this is not controlled for things like obesity, amount of wine consumed at dinner parties, exercise, other risk factors, including whether you're a flight attendant or not. We'll talk about that. So let's get back to history. Nobody in this room, I suspect, was alive and practicing medicine in 1944. Pretty good guess, huh? Well, then you don't remember treating breast cancer with estrogen. I can't make this shit up, guys. Treating breast cancer with estrogen. You have the before. I hope you never see a big fungating breast cancer like this in your careers. And the after, treated with estrogen. Another case, 1957. Some of us were born then. Another big fungating breast cancer before and after being treated with estrogen. The little note in the comment from Dr. Kennedy was, died 8 years later of coronary artery disease. Not from her breast cancer. Here's a woman that has metastases. Those of you who like reading x-rays, those are the big balls in her lungs on the far side, on the ribs in her lungs, and tumor regression with, big surprise, estrogen. But the best study on this came in 1981. 1981, some of you were alive, many of you might have even been practicing in 1981, a randomized controlled trial of tamoxifen and estrogen in the treatment of breast cancer. And if you look at those two curves, you'll be surprised to find they are identical. So why the hell do we use tamoxifen for all these ER-positive breast cancer patients? Wasn't about efficacy. Those two lines show equal efficacy. It's because of the side effect profile. If you look at the column that says TAM, about 12% of those women had vomiting, about 12% of those women had edema, 1% had vaginal bleeding. Let's say that many more times. 1% had vaginal bleeding. Remember, oncologists are medical doctors, not gynecologists. 1% had vaginal bleeding on tamoxifen, 15% had vaginal bleeding on estrogen. Oh, that estrogen's bad. It makes the uterus bleed. Not to mention 25% of them had vomiting. But the answer, equally efficacious. Now let's jump back to the Women's Health Initiative, because the Women's Health Initiative told us all this. In the initial publication, had they only been honest and had we had the eyes to see. The first row, highlighted in yellow, are the women who came into the Women's Health Initiative having never received estrogen or progesterone before. Not any estradiol, not any conjugated estrogens, not any progesterone, norethindrone, or medroxyprogesterone acetate. And what do you see? Their risks were, in the 5.6 years of clinical trial on combination estradiol and conjugated estrogen and progestin, no effect. Hazard ratio 1.06. That's the original publication. This is taken exactly out of that publication, unadulterated, except I highlighted the front row, the top row. All the risk for breast cancer in the estrogen progestin arm of the Women's Health Initiative came from the other rows, from women who had used hormones less than 5 years, 5 to 10 years, or more than 10 years. All the risk that created all the hoopla came from women who were not clean at entry into the trial. We have a blonde and brunette problem here, ladies and gentlemen. And if you look only at the 12,304 out of the 16,608 individuals, there's no risk of breast cancer. The headline should have been, hormone therapy safe for breast cancer. That's the proper conclusion. So what the hell happened with those other women? Oh, by the way, does anybody remember how many women were in that 26% increase? It was 8 extra cases per 10,000 women per year, or 0.8%, 0.8 of a woman per 10,000 women. So 8 extra cases per 10,000 women per year. Does anyone in this room have a credit card? Maybe I should ask it a different way. Is there anyone in this room who doesn't have a credit card? Well, your risk of identity theft, by the way, if you own a single credit card, is 8 in 10,000. So, by the way, if you fear hormone therapy and the Women's Health Initiative is going to give you breast cancer, well, you better throw away all your credit cards because you're at risk for identity theft, 8 in 10,000 for each one you own. And having had my identity stolen, you do not want to take that risk. So what did happen in the Women's Health Initiative? So here's what happened. Here's the 5.6 years of treatment of conjugated estrogen, medroxyprogesterone acetate, published in Maturitas, 2006. Now, what took them from 2002 to 2006 to come clean about this? I don't know, but it borders on, never mind. So if you look at women in the first panel, there's no pointer, but with invasive cancer in patients with no prior hormone use, the ones in that first row in the table I just showed you, those lines overlap. Okay? And estrogen progesteron's blue, placebo is, I guess, pink, and there's no difference whatsoever. But if you look at the ones who are in the table, all the other rows, prior use, 5 years, 5 to 10, et cetera, all the difference comes from those two lines, the difference between the line going almost horizontal and the line going vertical. But there's an interesting phenomena here. Look at the estrogen plus progestin line in the women who had invasive breast cancer and used hormones previously. Let's just do a little mind experiment and take that line and move it over to the other graph. There it is. It's exactly the same as the others. So it wasn't the fact that they had used hormone therapy before. It was the fact that they were either on or had used hormone therapy and were randomized to the placebo group. The conclusion there would be using hormones and stopping them reduces your risk of breast cancer. That's what may have happened there. But the answer is hormones did not increase the risk of breast cancer at all. Placebo reduced the risk of breast cancer, so I'll be selling placebo at the next IMS meeting. If you're going to see an effect of hormones, you're going to see it in new breast cancers, right? You should see it in situ cancers. The first cancers that are going to occur are in situ, right? We're not going to make a 4-centimeter cancer when we start hormone therapy. It just doesn't work that way. So in the Women's Health Initiative, we can look at the estrogen progestin group on in situ breast cancer. No difference, 7 years of data. Well, many of us like to think that conjugated estrogens lower the risk of breast cancer. And that was one of the conclusions in the 18-year data. But if you look at the in situ breast cancers and estrogen only, that's that, and it shows no effect there either. It doesn't show any effect in large Finnish databases. This shows that regardless of the length of time women used estrogen or estrogen progestin or any hormone therapy, no effect. And oh, by the way, this was a pretty big study, 498,000 women. I don't even think there are 498,000 women in the 3 states around Washington, D.C. And quite frankly, it didn't affect their when they started. Didn't matter if they started 50 to 54 or over age 80. No effect. No effect. Well, you should for sure see hormones raise the risk of breast cancer in women at very high risk of breast cancer because they have BRCA1 or BRCA2, right? And they still have breasts. So these women, if they have their ovaries and their uterus out, that's risk-reducing salpingo-oophorectomy, SRRSPO, and they're given hormones back, certainly it'll increase their risk of breast cancer, right? They're at very high risk, it'll increase it. We'll see it right away. And by the way, none of those are statistically significant, and there's about 5 or 6 other studies just like this. What about women with breast cancer? Certainly, if we gave them hormone therapy, we would cause more breast cancers. They're obviously at high risk. They already had breast cancer. This is what the data shows. You better keep your seats when you see this one. These are studies from 1995 to 2002 looking at the use of hormone therapy in women who had breast cancer and are breast cancer survivors. Every single study but one shows either no difference in the recurrence of breast cancer or a reduced recurrence in the risk of breast cancer. And by the way, we have the Swedes to thank, no offense intended, Dr. Hirschberg, to thank for the outlier, this one right here, the Habits trial, increased recurrence risk. They even published it twice. The Habits trial is actually a very good study. it shows how bad a study design can be. I use it with my students all the time. Why is it a bad study? Not because it showed an increased risk of breast cancer recurrence in women on hormone therapy who had had breast cancer, but because the investigators failed to establish a baseline at baseline. Who does a study of breast cancer risk recurrence without checking to see if women, when they come into the study, have breast cancer? I gotta tell you, they didn't do baseline mammograms in the HABITS trial. Who does that? No offense to the Swedes, otherwise a good study. A perfect example as to how not to do a study. Well, after the WHI, as Dr. Hirschberg beautifully showed, estrogen took a tank in the US. It was prescribed in a little less than in Sweden, 22.4% of women, not 30, as you said. And it went down and is now about 5%. So hormones went down, use of hormones went down. Certainly if hormones cause breast cancer went down, right? No. The risk of breast cancer, according to the CDC, went up. Same time frame. So let's superimpose those. There's the going down, an 80% or so decrease in hormones, and a 7% or so increase per year in breast cancer. Something else is going on, people. It's not the hormones. And in the final mortality outcomes in the 18-year data in the Women's Health Initiative, it shows that hormone therapy, with or without progesterone, in this case, medroxyprogesterone acetate, reduced all-cause mortality, including breast cancer mortality. So everybody here practices medicine. We got a bunch of primary care physicians or generalists, and I'll bet that some of you are actually on statins. I'll bet you some of you are on tamoxifen or raloxifene or maybe even fenofibrate. So let's look and see what those drugs do to deep vein thrombosis. Here they are. The top group is conjugated estrogen and medroxyprogesterone acetate from the WHI. Then estrogen only, the CEE alone group from the WHI. 17-beta estradiol in the West trial. Those are women who already had a stroke and our average age, I think it was 80 or maybe it's 70, I forget. But these are the risks of additional cases of deep vein thrombosis, venous thromboembolism, pulmonary emboli, and other common used hormones like tamoxifen, raloxifene, and fenofibrate. And I showed you that transdermal estrogens had no effect. These are the dangerous drugs. 46 extra pulmonary embolisms on tamoxifen per 10,000 women per year. That's a dangerous drug. Let's look at statins. Statins help people avoid heart attacks. I'm not going to get a lot of arguments about that. They lower LDL cholesterol and they save hearts, but they cause breast cancer. Pravastatin is the worst. 77 extra breast cancers per 10,000 women per year in the CARE trial. So before you save someone's heart, maybe they should have a double mastectomy. Because these are dangerous drugs when it comes to breast cancer. And I'm sure no one in this group has ever prescribed antibiotics. Because antibiotics are associated with incident breast cancer and breast cancer death in a dose-dependent fashion. I didn't make it up. It's published in JAMA in 2004. I can't imagine. No one in this room would ever prescribe antibiotics. We even prescribe them over the phone, for goodness sakes. So what are the risk factors that we can modify? I want to point out this one about alcohol while you're enjoying your wine. There's no safe amount of alcohol, by the way. For breast cancer, there's a signal at 1 glass a week. 2 glasses per week, sorry for the French, or the Portuguese, or the people from California or other wine-growing regions. But these are real risk factors. They're not imaginary. And they are about the same as conjugated equine estrogens and medroxyprogesterone acetate in the Women's Health Initiative. What about micronized oral progesterone and breast cancer? We now have 2 studies. This one you're probably familiar with from Fernier from the E3N cohort, some 80,000, I think French and Belgian women, school teachers maybe? No increase with dydrogesterone or with micronized progesterone. And recently, and I mean recently, still not published in print form, is this confirmatory trial showing that micronized progesterone with estrogens of any type had no increase in the risk of incident breast cancer. Well, you know what they say, it's deja vu all over again. I wrote a paper in 2013, said, what if the Women's Health Initiative had used transdermal estradiol and oral progesterone instead? And we did an analysis based on the existing literature at the time as to what would happen for breast cancer, thrombosis, heart attacks, strokes, the whole WHI story. And the answer is they would have found nothing. No risks, just a decrease in fractures, maybe a decrease in cardiovascular events. So when we come to a zombie idea, let's get real and let's think about what the real story is. So I would conclude with, compared with placebo, the risks associated with hormone therapy in early menopausal women are statistically not significant. Hormone therapy risks are rare, less than 1 in 1,000, and even more rare when initiated in women who are less than 60 years of age or less than 10 years since a surgical menopause. The magnitude and type of those risks are less than or similar to other commonly used medications like statins and antibiotics, and as it relates to thrombosis, tamoxifen, raloxifene, etc. Hormone therapy reduces all-cause mortality, heart disease, fractures, new onset diabetes, and thus the benefits far outweigh the risks. And in conclusion, down here at the bottom, transdermal estradiol with or without oral micronized progesterone is not associated with deviated thrombosis or thromboembolism, and transdermal estradiol with or without micronized progesterone not associated with any increase in breast cancer risk. So I'll leave you with this. We all live with this every day. Max Planck, physicist, German physicist, who discovered quanta theory and won a Nobel Prize for it in 1918, who's also a classical pianist and a revolutionary physicist. He said, a scientific truth does not triumph by convincing its opponents and making them see the light, but rather because its opponents eventually die and a new generation grows up that is familiar with it. Thank you very much.
Well, thank you very much, James, for that tour de force. I think you'll all agree. We do have, and the hour is late, but we do have a little time for questions, if anyone would like to pose a question.
And dessert.
And yes, you get rewarded with a dessert if you ask a good question. Perhaps I could ask, one question. Please, if we could have your patience, thank you. If I could ask one question. So, do you think we need to could we ever repeat WHI with the right preparation for the right woman, for the right indication?
So, is my mic back on? So I would say that that's a wonderful idea. But I think the only way that could happen would be if the largest economies in the world got together and decided it was an important thing to do. Looking at what the Women's Health Initiative cost in the 1990s and converting that to real dollars, this would require major investments from the EU, from the US, from the Chinese, the Indians, etc. The large first world economies would have to kick in probably about $2 billion to do the study. And I would bet, because epidemiologic findings are not proof of cause and effect, but if you have enough of them and they are independent of one another, it's very unlikely that a randomized trial is going to find something different. And I applaud Dr. Hirschberg and the people that are doing this randomized trial of micronized progesterone and other progestins who will come up with an answer. But I'll bet that it'll be very similar to the observational data, that it was properly done. And I doubt, Nick, that anybody is going to want to pony up $2 billion to do the study that I think would be definitive, but unlikely to ever be done, unfortunately.
We can always hope.
We can hope, but governments spend money on guns and other things, not on women's health. Sorry to say.
Well, the hour is late, sir, and people want their
Thank
dessert,
you all
so
very much. Enjoy your dessert.
So with that, I would like to close by thanking the PREIS School for supporting this event, and particularly to our two excellent speakers, Angelika Hirschberg and James Simon. And thank you to you for coming. And rather than thinking of menopause as a challenge, I think it should be a time of opportunity to make a difference for women's lives for the second half of their life. It should be middle youth, not menopause. Thank you very much.